Virtually every cardiac condition is chronic and requires self-care on the part of individuals and their families. The focus of our work has been to identify the self-care activities that are important and to identify people's strengths that can be incorporated into improving their self-care abilities, but also to identify individual and family barriers. Depression is a great example of psychological barrier to engaging in self-care. The rate in the population of depression is about 2 to 3%. The rate of clinical depression is about 25% in cardiac patients, and of depressive symptoms, which have some similar consequences, is up in some cases in hospitalized patients to 75%. Anybody who has depression or depressive symptoms has a terrible time adhering to any of the self-care activities they need to, like taking medications, being physically active, eating whatever diet is prescribed for you, monitoring symptoms. People who are depressed don't have the energy or the will to engage in those sorts of activities. Cognitive behavioral therapy, which is a well-accepted therapy for effectively managing depression and depressive symptoms, we built that into all of our interventions so that we recognize depression early on, we recognize it if it develops later. Cognitive behavioral therapy can actually prevent the onset of depressive symptoms because it works to help people work through really negative thoughts they have about their condition and even, erroneous thoughts. People who have depression often turn a simple event into a catastrophe that is going to destroy their life. It's just reconceptualizing a situation, sort of reframing it so that you see how to work through a formerly insurmountable barrier. We have really pioneered the use of that sort of therapy in a simple self-care intervention because it has such a strong effect. There's this interesting phenomenon called the theory of emotional contagion, which says that emotions, negative emotions and positive emotions, can be transferred easily in a relationship between partners. It's very common for cardiac patients to be depressed, then it's more common for their caregivers to be depressed. And it actually works the other way too. So you can have this bad interaction of depressive symptoms, of poor quality of life going between the patient and the caregiver. So that's another good reason to attend to the caregiver instead of just the patient. So when we provide interventions to caregivers, they get the skills and the knowledge to not be so burdened by the condition, but they also get some direct attention for their own health, for their own depressive symptoms, for their own quality of life. And really the act of providing an outlet to caregivers is really found to be helpful just in improving their own psychological health.